Abdul Hamied, Deputy Director within the National Healthcare Inequalities Improvement Team. So yeah, I was building on, my presentation built on some of the sessions held in the morning, which highlighted some of the big challenges that we got around health inequalities. And of course, the role that NHS can play, but more importantly, the role that non-NHS partners can play. So as a result, my presentation was actually outlining the challenges that exist in healthcare inequalities, the social determinants that have an impact, but more importantly, what can NHS do in terms of tackling health inequalities. I then went through the framework that we developed, which is based on experience from the pandemic and other health inequalities work, which highlighted that we have 5 strategic priorities as a national team. Priorities 1 is around ensuring inclusive elective recovery, making sure that no one is left behind as we bring the services and restore services. We talked about primary care recovery plan, and of course I mentioned the urgent and emergency care, and in particular, the fuel that fires the urgent and emergency care and the emergency department is people living in some of our most deprived communities, those vulnerable communities. That was our strategic priority 1. Our strategic priority 2 was around digital exclusion, or ensuring we avoid digital exclusion. However, we're going to talk more about that at our session tomorrow afternoon. I described our strategic priority 3 about the use of data and how important it is to have timely data, accurate data, and that's complete. And the work we're doing as a national team in developing a health inequalities improvement dashboard to help us track progress on the areas that we are focusing as part of our core 20+5 approach, but also making sure that we have the appropriate coding around ethnicity to make sure that we are able to get the full richness of the data to gather the insight and therefore target services. I described strategic priority 4, which is around accelerating preventative measures, because we heard early in the morning the importance of prevention. We are a sickness service. We need to shift towards a health and wellbeing service. So again, there was an element of a focus around prevention. And lastly, I talked about our strategic priority 5, which is around about leadership and accountability, how we are working with leaders, chairs, non-exec directors, and SROs for healthcare inequalities within integrated care systems, primary care, and of course, NHS Trust, to make sure that we have the leadership for the healthcare inequalities agenda, and that people can hold people to account or be held to account in making sure we narrow the gap based on data. I then described our focus approach around core 20+5, an approach that we developed which aims to give us a bit of focus so we can get some traction and impact over the next few years in order that we can narrow the life expectancy gap that we've got as part of mission 7 of the Levelling Up paper. I described the adult core 20+5 framework, the core 20 being the 20% most deprived communities, i.e. based on the index of multiple deprivation. The plus groups, that's people like homeless, gypsy Roma travellers, people with learning disability, those in the care system, people from ethnic minorities, etc., so what we would call underserved groups. And then how we arrived at those 5 conditions that make up the adult core 20+5. And then of course I described the core 20+5 for children and young people, which is exactly the same model. However, the 5 conditions are different. And they are conditions based on the evidence that demonstrate that these are the conditions that have the negative impact on life expectancy. I then described the eco-delivery system that we've been developing, because we are a small national team. We don't have a huge program of budgets where we invest in those conditions I mentioned. We work through others, the national programs for cancer, for mental health, for maternity. They are the people that are actually charged with delivering the narrowing the gap agenda. We obviously provide the enabling support, the policy levers and expertise. And then obviously in terms of some of the delivery system, I mentioned the Core 20 Connector program. We're currently working in 32 integrated care systems with Core 20 Connector programs. Those programs have been led and delivered by voluntary organizations. We've got over 50 organizations from the community voluntary sector involved in delivering those on the ground, working with trusted communities on different conditions, part of the Core 20+5, through volunteers and employed coordinators. And those are our kind of community champions. I then described the Core 20 Ambassadors program that we have. These are professionals who are working and committed in making a change in terms of healthcare inequalities, and we support them to become change agents, and we provide them with information, insights and some development to enable them to provide a role much more effectively. I then talked about one of our other pilot programs, which is the Core 20 Accelerator programs. This is a pilot program delivered with the Health Foundation, the Institute of Healthcare Improvement from the US, and ourselves. It's a 12-month quality improvement project aimed at supporting 7 sites, 1 across per region, to go further faster in terms of addressing an impact on Core 20+5 or one of the conditions. And then I mentioned innovation. how innovation is really important to help us tackle healthcare inequalities, and how we are working through our academic health science network partners, but also other partners, including the National Innovation Accelerator Programme, in trying to tackle and further amplify the opportunities for innovation in tackling healthcare inequalities. And then at the end, it was just describing people the work that's happening around the Health and Care Act, or Health and Care Act for 2022, and how the duty around healthcare inequalities is very, very clear for NHS England, for integrated care systems, and through integration. So that was the kind of core focus of my presentation. There were some really interesting questions that we had as a panel, including how we support communities in building trust, how we ensure that our workforce reflects the diversity of our communities, and how we are able to work much more closely with social care. So APNA is fundamental, because as I mentioned earlier, we can only deliver so much as a national team. Most of the delivery, all of the delivery happens on the ground. So our regions, our systems, and our local places and primary care play a huge role in that. But having champions that are part of the Asian Professional Network Association committed to this agenda, because as you know, the BME communities make up a significant percentage of the workforce. I think we heard early on from Amanda Pritchard that 25% of the workforce is from BME communities. And if you look at different clinical areas, there's a much bigger representation. So having people that look like the communities that we are working with, that are able to understand the communities that we are targeting, that are able to converse with the communities and have a cultural understanding of the communities that we are trying to target, it makes our job much easier, because we can count on the richness, the insight that these colleagues bring, but also use them through their trusted channels to help us spread the message and get the delivery on the ground. I think obviously networking and spreading the word is really, really important, especially when we rely so much on people to do some of the work that I've described in their voluntary capacity. Because a lot of these clinicians, a lot of these professionals, their job isn't around equalities. They're there as a general practitioner, they're there as a consultant, but because of their interest and commitment, they go beyond their call of duty. They make sure everybody who comes to them gets equality and diversity of sport, but they do a lot of work in their voluntary time, in the evenings and weekends. We heard quite a lot of the colleagues mention early on how much of their time they give up for the benefit of their community through their community development approach. And therefore, it's really important that we are able to share with them some of the insights, some of the priority areas that we're working, but also perhaps connect them with some of the tools and resources that we have so that they can use them to be more effective. And then obviously listen to some of the feedback that they've got on how we might be able to do more.